Nerves. Published by WordPress.com. Ulnar nerve injury, anatomy, course, and clinical presentation. Root values. C8, T1, with communication from the median nerve via the C7 branch. Origin and termination. Origin, medial cord of the brachial plexus. Termination, at the flexor retinaculum, where it splits into superficial branch, sensory and motor functions. Deep branch, motor functions. Course of the ulnar nerve. 1. Axilla, upper arm. Travels medial to the axillary and brachial artery. 2. Middle arm. Pierces the medial septum from before to backwards. 3. Lower arm. In the posterior compartment, behind the medial septum. 4. Elbow. Passes behind the medial epicondyle, between the two heads of the flexor carpi ulnaris, FCU. 5. Forearm. Travels along the medial side, between FCU and flexor digitorum profundus, FDP. And 6. Wrist. Approximately 5 cm above the wrist, the nerve becomes superficial and lateral to the FCU. It then passes superficial to the flexor retinaculum at the wrist. Ulnar nerve branches and function. Superficial branch. Motor. Innervates the palmaris brevis muscle. Sensory. Provides sensation to the palmar aspect of the medial 1½ fingers. Deep branch. Motor. Innervates the hypothenar muscles, adductor pollicis, interossae, and the medial 2 lumbricals. Additionally, it innervates the FCU and the medial half of the FDP. Sensory. Provides sensation to the palmar cutaneous nerve of the palm and the dorsal cutaneous nerve, medial 1/3 of the dorsum of the hand and the medial 1½ fingers. Mode of injury and effects. 1. Cut injury at the wrist. Sensory. Loss of sensation over the palmar surface of the medial 1½ fingers. Motor. Weakness or paralysis of the hypothenar muscles, adductor pollicis, interossae, and medial 2 lumbricals. Deformity. Partial claw hand, less severe than at the elbow, especially noticeable with limited flexion of the little and ring fingers due to paralysis of the medial half of the FDP. 2. Medial epicondyle, cubital tunnel, injury. Sensory. Loss of sensation in the medial 1/3 of the palm, medial 1/3 of the dorsum of the hand, and the medial 1½ fingers. Motor. Weakness of FCU and the medial half of FDP. Deformity. Partial claw hand, with positive findings on special tests. Plus V Froment's test. Weakness in adductor pollicis. Plus V card test. Weakness in interossae muscles. Key clinical signs of ulnar nerve injury. Claw hand. Due to weakness in the interossae and lumbricals, leading to hyperextension of the MCP joints and flexion of the IP joints. Positive Froment sign. Difficulty holding a piece of paper between the thumb and index finger, indicating weakness in the adductor pollicis. Positive Tinel's sign. Tingling sensation at the site of nerve compression, especially at the cubital tunnel. Treatment and management. Conservative. Splinting or immobilization to prevent further nerve damage. Physiotherapy to maintain hand function and prevent contractures. Surgical. Nerve repair or decompression if there is a significant loss of function or progressive symptoms. Tendon transfers or arthrodesis in cases of long-standing paralysis or deformities.